Hello, everyone. It is a great pleasure to see you here. This is another edition of Heart to Heart Conversations, and I am more than delighted to be joined this time by Professor Flavio Ribichini, the director of the Cardiovascular Center at the University of Verona in Italy. As you know, Heart to Heart Conversations can be followed live at X, former Twitter, Facebook, YouTube, LinkedIn, or you can join via PCR online, where you can also ask questions. The topic for today is actually a very important one, since it concerns a large amount of patients worldwide. And that is, what is the future of coronary interventions? That being said, Professor Ribichini, today, most of our patients are being treated with a drug-eluting stent. How do you see this presently? Do you think there are any shortcomings of that sort of therapy?
Thank you, Dejan. Good morning, friends. Thank you for attending this talk. Well, the question is quite obvious. Stents are great. They have changed totally the treatment of coronary artery disease worldwide, but they are still not perfect. We do believe that we can do better. And is the real limitation is the, let's say, biological incompatibility of metal with tissue in the human body. We know that the longer the size of the stents, the higher the negative consequences of PCI. So I think that the most important limitation of stents is the length. So also the small diameter of the stents correlate with occlusion and restenosis. So definitely we have room to improve.
Yeah, so the question is, one of the problems that we hear often is that when you leave the metal behind, the events will keep coming which are related to the stent. So how do you see the evidence that tells us that there is a continuous risk of stent-related events, not only in the first year post-implantation, but after the first year as well?
Yeah, there is absolutely no doubt about that. I think that expert operators know it well. Young people should be very aware of that. The longer the metal we implant, but it's a matter of millimeters, the higher the recurrence of patients. Actually, at 10 years follow-up, 50%, 1 out of 2 patients treated with metallic stents will come back for any reason. Might be death, well, death they don't come back, but myocardial infarction of restenosis or thrombosis. So this has to be one rule for any interventionalist, that the shorter, the better. Also, the larger in terms of diameter is the better. And this is where you have to work to offer the patients a complementary alternative to use the metal where it is very important and useful, but to reduce it when possible.
Yeah, so the question is, if we look at this data of the pooled analysis of randomized patients, and this is the data which many people refer to, published 5 years ago from the New York group, and they pooled several randomized trials together, and they basically concluded that with new stents annually after the first year, you may think that you will have a 2% rate of stent-related events each year. Not in the first year. In the first year, it's around 5%. But after the first year, each year after the first year until the 5-year follow-up, there will be a 2% stent-related events. Now, when you think about the use of intracoronary imaging, that is one of the things which was not standard inside those trials which were analyzed. So my question to you, before we start talking about the device-based alternatives to metallic stents, do you think that the use of intracoronary imaging, if it would be increased, could further reduce the burden of stent-related events that we see nowadays with the contemporary new generation DES?
Well, I think there is no discussion that doing a good vessel preparation and a good stent expansion and a good stent sizing based on intravascular observation offers better results than angiographically or just visual estimation of things. How this might impact actually the very long-term outcome, we don't know. We know that we will have less restenosis, less TBR, less thrombosis, lower death in important vessels like the left main if we do intravascular imaging. I'm not aware about very long-term comparisons of angio versus intravascular imaging. I have to say that biology will play a role which is more important than physics. Physics is about length and diameter and flow. Biology is something that takes longer, so I'm not convinced that this big difference can be also translated at 10, 15, or 20 years.
This
Sincerely.
is a I think this is a very important point you made, because when we look at those people coming back after 5, 6, 7 years, we often see neoatherosclerosis, a new atherosclerotic plaque inside the old metallic stent. And of course, there's a question whether we can do anything about it to prevent it. So, yeah, maybe different.
It's hard to believe that this will be prevented by intravascular imaging.
I agree. So we can work on let's say the first year or the several next years, but this long-term follow-up is a question. So does a new device help us here? Tell me, what is your impression on the emerging therapies with drug-coated balloons? How do you see the development of these therapies so far? And how do you assess the evidence?
Well, it's a lot of questions. I will start for saying that since the very beginning of my understanding of intravascular interventions, I have very clear that the shorter the length of the metal, the better for the patient. This is a little bit difficult to balance with the good angiographically beautiful result immediately after the interventions, because when you have topically metallized artery, it looks great, it looks brand new, but we know that it is very bad. When you leave dissections or residual lesions, it doesn't look that great, but we know for sure that this is better for the patient, also in terms of a future intervention. So first of all, it's a change of mentality. Beauty is not a part of functionally improved revascularization. So let's try to have this in mind, that what we don't need to have a perfect tube with very net contours. What we need is good physiology and reducing the metal to the minimum which is necessary. So that being said, the addition of alternative anti-proliferative strategies like balloon-coated, drug coating balloons may solve the problem of the recurrence due to the neointimal growth without leaving the stimulus of having the foreign body forever. So the hybrid idea of using stents where needed and accepting dissections, which is a way of healing the dilatation, and releasing a drug which can be cytotoxic or cytostatic, this is of course making a lot of sense. I have been applying these, for instance, normalizing physiology at the price of putting very long stents, on my opinion, is not a good deal. Normalizing physiology with acceptable results, reducing metal and dilating the lumen of the artery, it's much more sensitive.
Okay, so when we speak now about the evidence, I mean, you said that it makes biological and, let's say, clinical sense to sometimes use drug-coated or drug-eluting balloons instead of metallic stents by reducing the length of the metal or also avoiding it altogether. Now, the question is, how far away have we come, or how far have we come in terms of evidence for this new therapy for coronary interventions? Now, when you think about the 3 large randomized trials, in my humble opinion, over the past, let's say, 7 or 8 years, starting with the basket small q in 2018, then progressing to REC Cage Free, the Chinese trial of last year, 2024, and then ending with just now at TCT, just a week or a few weeks ago, there was a publication of a large study, Solution de Novo, which tackled this issue, DES versus DEB for de novo coronary lesions. So what is the common ground of these 3 large randomized trials? And I think there are 2 things which need to be looked at. First, what was the lesion subset? Interestingly, they built kind of nicely one on each other in terms of the lesion subset they tackled. We know that historical evidence, also observational, pointed towards some benefits of drug-eluting balloons in in-stent restenosis, but also for small vessel de novo disease. So if you look at the first trial, Basket Small 2, 2018, it basically showed that the DCBs were non-inferior in vessels which were below 3 millimeters. Then last year, we basically, with the Chinese trial, the rec cage-free trial, saw a warning sign that a specific DCB that were used in that trial was actually shown not non-inferior. For the purposes of language clarity, we can say it was shown to be inferior to DES in large vessels, in vessels which are 3 or more millimeters in diameter. But this year, just a week or two ago, at the TCT, we saw a publication of the Solution de Novo trial, which showed that another balloon, not the same one that was used in the previous two trials, this one is sirolimus-eluting solution balloon, that it was non-inferior in both small and large vessels. So Basket Small 2 and the rec cage-free trials both seem to have established non-inferiority in small vessels, whereas the rec cage-free showed a red flag for large vessels, but the Solution de Novo said both small or large vessel DCB seems to be non-inferior. Now the problem is, in each of these three trials, there was a different balloon that was used, either paclitaxel coated with different excipients, which is the delivery, the materials used for the delivery of the drug, so that the kinetics of those drugs, not only the drugs were different, either paclitaxel or sirolimus, the kinetics of the drugs, which are influenced by the nature of the drug, but also by the excipient, were different. So my question to you is, when we speak about the evidence, can we speak about a class effect? Can we say that the evidence from one trial should apply for other DCBs as well? What is your feeling at the moment about this?
Well, let's make things simpler. I think that the first step in research in this field is looking for non-inferiority. But actually, as a clinician, what I'd like to offer to my patient is a superiority. So yeah, of course,
Very true. Very
doing
true.
something non-inferior is not much better than doing what we were doing before. So that's the first point. And these three studies are very different. Different drugs, as you said, is different manufacturing, is different carriers, and is different vessel subset. They have something in common, that there is no advantage of stents when the vessels are below 3 millimeters. Even in the Chinese study that has been criticized because of the time, it is something that we have not tested very thoroughly. But again, the difference in favor of stent disappears totally when the vessel is less than 3 millimeters, confirming the Picoletto data. With the new solution, it's true, it's a different drug, so we need to understand better if there is any difference. For sure, from the data we have already available, there is no class effect. Paclitaxel is cytotoxic. All the limus drugs are cytostatic. They need a receptor to work. They probably induce less positive remodeling, but all these need to be proved in head-to-head comparisons and in superiority trials against DES, because I think it's very difficult. I mean, we should not deny where DES do perform very well. A short stent, a large stent in diameters, in a focal lesion, in a proximal LAD, my dream is that one day we would prove that this is as good as a mammary artery. We are not there yet, but for sure we will never be there if we implant 25 millimeters of stent. Probably with 10 millimeters we will get closer, but this is what I want people to make really very conscious about. We need to limit the metal and use where it is needed. So if then we go to the inclusion and exclusion criteria of the studies, all this data is very weak, because we still need to get into details of bifurcations, of calcified lesions, of acute MI, of total occlusion, or indications that are very appealing because they do put in evidence the weakness of the permanent metallic prosthesis, but we still don't have non-inferiority. Unlikely, I would like to see a superiority.
Yeah, I agree 100%. I mean, I'm a fresh user of DCBs. You're a long-term user of DCBs. And I know from a personal communication from you that you've been using it in the previous years before basically this randomized evidence that we just showed was out there. Now, with the solution trial, I think that the advocates of the DCB use are better off. I think that we can say that now we have a large study, at least showing at least non-inferiority within a year, which I think is encouraging. But now back to you and your personal experience. I mean, you've been using it before these studies. So how do you see this therapy? It almost seems to me that to a certain degree, DCBs would be used even without these large randomized trials. Tell me, what do you think about that?
We have to be very honest and clear on that. I've been using DCB more than 10 or 12 years ago when the indication was in-stent restenosis. We have been trying desperate therapies for in-stent restenosis, even intravascular radiation, brachytherapy. Why DCB works so well in in-stent restenosis? Because in-stent restenosis is a very highly proliferative tissue. It's a young tissue. It's a tissue that is being grown in the last 3 to 4 months. So these rapidly replicating cells are very sensitive to radiations, or are very sensitive to cytostatics or to cytotoxics. So this is the best milieu in which you can apply anti-restenotic models. And it has been shown in randomized trials, and it had been for ages a class 1 indication to treat in-stent restenosis, either after bare metal stent or after DS with local drug delivery within the stent. That being said, this remains the most supported and unarguable indication, provided that the intervention is guided by intravascular imaging. Any case of stent failure should be interrogated by intravascular imaging. If there is stent under expansion, under scission, or fracture, probably a second stent would make sense. If the vessel is small and there is no room for more material making this Russian doll inside the artery, and you have neointimal proliferation as the cause of lumen narrowing, then there is no doubt that local drug delivery is the way to go. Like at the time of brachytherapy, it was shown to inhibit this neointimal growth. So this is what we know. I don't know exactly why in the latest guidelines the in-stent restenosis treatment with DCB has been downgraded from indication class 1 to AB. This is a matter of discussion. Still 2A, it's still a strong indication. And then we move to the native vessels. So we have evidence that in small vessels where stents do not perform optimally, avoiding the metal is good. So this is the first indication for DCB. Then it makes a lot of sense to reduce metal in bifurcation. So we know that provisional stent 1 instead of 2 is better. So very likely 1 stent plus DCB would be better than 2 stents or better than non-coated balloons. Third, calcified lesions. We know that if we cage a calcified vessel with a stent, which is common practice, there is no opportunity for this vessel to induce positive remodeling. This is a good perspective of breaking the calcium, delivering the drug, and then leave it grow. So all these indications that are coming are promising, but need to be proved. And the last one, which is numerically irrelevant, but theoretically very important, for instance, you might know that never a drug-eluting stent have been shown superior to bare metal stents in saphenous vein grafts. You know that? Never in a randomized trial. That means that veins are different to arteries. But you know what? The drug-coating balloons with paclitaxel are as effective in veins like in arteries. So this is telling you how undifferentiated is the efficacy of paclitaxels in the vascular circulation.
Yeah.
And this adds, at least in theory, potentials for this drug and this therapy to enlarge our indications.
It's very good that you say this because at TCT, the Proctor trial was also published, which showed that treating the SVGs is better than treating the native disease. So, in that light, yeah, DCBs might be a future there as well. So, let me just summarize. What you just described are different lesion subsets, which clinically and from the end, from the angle of an interventional cardiologist, might offer themselves for the DCB treatment. In terms of evidence, what we have is three large randomized trials in basically all comers. So you had ACS in roughly half of those patients as well, and you had small and large vessels. So as a wrap up, the direction that the evidence is taking seems to be encouraging, where DCBs, at least within that first year, seem to be non-inferior to DES, with a warning sign from the Chinese REC cage-free trial, which showed the warning in large vessels. So I guess that we will need more evidence to be stable there, but I also assume that the use of DCBs will increase. Before we wrap up the story of DCBs, just a practical advice from you. We hear that two important elements of a successful DCB therapy are recurring. One is the degree of lesion preparation. How important is a thorough lesion preparation? Or is just a pre-dilatation with an SC balloon enough? And second, what to do with dissections? How is it that you when you face dissections, how you make your decision to stay with a DCB or to escalate to a DS?
Okay. So vessel preparation is important for any intervention. It's not only for DCB is fundamental because you will not have a scaffold. But it's also important for stent because if you don't prepare a lesion properly in a calcified vessel, the stent will fade. So the fashion of direct stenting was a bad one for us because we simplify the technique, which should not be. You know, we are now very keen on talking on lifetime management of valves. I think we should also think about lifetime management of coronaries. So one intervention should last, I don't say forever, but the better. And for that, vessel preparation is important for stenting and for DCB. For DCB, you need to obtain the best dilatation of the vessel possible, going one-to-one to the artery side to prepare it, without being very scared about dissections. Dissections can be managed by a stent, if it is occlusive, by long dilatations at low pressure, or by the using of scoring or cutting balloons with blades. And this will improve the final result. Then, of course, the decision whether to leave a dissection or not has a lot to do with experience, but I will cut this explanation very shortly, Dejan. We did dedicate a PCR, a webinar. It lasts 1 hour with other experts. I had the privilege of facilitating this. It is called Dissections After DCB, Stent or Leave It. The webinar is available on the net, and I invite all our friends to review it because it's very practical with very good advices on how to take this sometimes difficult decision.
Very good. I like the answer. So when we now speak about the future of coronary interventions, we have for now said DS are good. We are still going to be using metallic stents. We will see how to improve it by using the intracoronary imaging and better understanding the disease which is underlying. Then we've introduced DCBs, which have an established indication for ISR and are now emerging as an option for de novo as well. So the final part of the story are BRS, bioresorbable scaffolds. Now, how do you see the story of bioresorbable scaffolds? Is it closed or is it ongoing? We know that there are new iterations of BRS, of resorbable scaffolds. How do you see the evidence so far, and what do you expect in the future?
Well, I start with a confession. I have always been a believer on bioabsorbable scaffolds since the beginning, because I do think that this is something different. We have been implanting stents for nearly 30 years, and it has always been the same. With more metal, with less metal, with one polymer, without polymer, with a drug, with another drug. It's more or less the same. The only difference, even drug coating balloon is the same. It's just inflating a balloon. The scaffold, it's an amazing technology. We know the bad and the good. We know the bad from the first studies with the PLLA that at a midterm of 1 to 2 years, we have more thrombosis. And this is because of the very slow and long-term period of reabsorbing, and probably because the need of very careful lesion preparation. But from that experience, we know the good part. We know that in AIDA, for instance, we have seen that after 5 years, it is not worse than a good science stent. And we do have results of 10 years with complete vessel healing and with disease progression that is more aggressive in other points rather than where the ederologists have done the job. So we do still need to understand better this technology. And for instance, with the magnesium platform, we know from Biomag 1 there are good results. The Biomag 2, it's a randomized international 1 to 2 compared to drug-eluting stents that is revitalizing this hope of doing something better. And the association of drug without scaffolds, DCBs, plus a scaffold that will disappear in case of occlusive dissection or insufficient lesion preparation, I think is the top thinking. If we want to think about the future, we should not be happy with non-inferiority, because if you aim at non-inferiority, you will remain at the same level. We should aim at superiority. This is a step forward. This is what we need. Of course, it's not easy. It will take years. It will take thousands and thousands of patients, but the theory is there. I do still believe that with the best iterations of bioabsorbable scaffolds plus DCB, we might do something superior than before. And thanks God, the good old stents are on the shelf in case of need.
Yeah, so I think that when we speak about the new iterations of BRS, it's interesting, at least in my humble opinion, to see that there are 3 domains which change as opposed to the absorb story, which we know how it ended with more stent thrombosis rates as opposed to DS within those 3 years, which was the resorption time. After that, the event rates were actually similar. But during that period of resorption, the event rates were higher with the first generation BRS. Now, there are 3 domains which I think are changing, and it's interesting to follow that. First, the polyl lactic acid is either being a bit changed in terms of strut thickness, or it's being changed to another material like magnesium, as you said, or even iron. The second domain is, as I said, the strut thickness. It was north of more than 150 strut thickness with the first generation, and now we are decreasing it. With PLLA, we have different versions of stents which are 100 or even less, up to 127 microns. And we have with magnesium and iron, even thinner struts. With iron, it's even 70 microns. And the third area is the resorption time. We know that the magnesium-based BRS has a resorption time of approximately a year, which is much less than the first generation PLLA bioresorbable scaffold. So I guess that with these changes, we will await what the study results will tell us and how this technology can supplement what we already have, which is a DES, and what emerges, which is a DCB. It might ultimately be a combination of all these 3 technologies, where you pick the right technology for the right patient or the right combination of technologies for the right patient. Now, a very personal assessment from you then. What or how do you see the future of coronary interventions given what we have discussed so far?
As I said, we should aim to something which is superior to what we have been doing. It will not be easy, but the road is clear. It's reducing the metal, enlarging the diameter of vessels, and for that, intravascular imaging adds safety and efficacy. And that is the combination of good drugs without metal, either with very short, very large pieces of metal, or with bioabsorbable scaffolds with rapid bioabsorption, like the freeze-solve model that after 1 year, we are doing OCT after freeze-solve, and there is nothing behind after 1 year. We need to have good radial strengths and good antiproliferative drugs to prevent neotherosclerosis. So this mixture is our part. as interventionists. But we have to remember that we are also clinicians, and lifestyle of a healthy lifestyle in the patient is fundamental. Exercise, diet, blood pressure control, diabetes control, lipids control. These are fundamental options for good long-term results. Drugs, the new drugs in the market that we are learning that are good for everything. So it's a combination of medicine. It's not just devices, metal, drugs, local deliveries. It's patient behavior, it's education, and it's drug. So this is the future. And I've been working in this field for more than 35 years. I've seen the results of a mammary artery for more than 35 years. And my wish is to offer the patient at least, I wouldn't ask to be superior to a mammary, but as good as a mammary. And if we put all together, patient's behavior, drugs, and top technology, I think that I will stop working with that dream becoming true.
Very good. That's very nice closure. I think one more thing, lifetime management, what you said. I think this is really lifetime management for coronary artery disease. That might be the future of coronary interventions. When we see the patient first, when we diagnose the coronary artery disease first, we should plan a lifetime management of coronary artery disease, which will entail intracoronary physiology, intracoronary imaging, different devices, a combination of DES, DCB, BRS, and finally, what you said, optimal pharmacology and lifestyle modification. Thank you very much, Professor Ribichini. It was great. It was a great conversation.
It was a pleasure there.
Thank you. And I would like to remind everybody that if you want to learn more about DCBs and about the Solution De Novo trial, there will be a PCR webinar coming on November 19 on this topic. And there is a series of webinars which we have already done and are planning to do on this topic. So stay close to us. Thank you very much.